Hello, my name is David James, and I would like to share with you our journey in creating a space for safe mobility. So I work in the Department of Professional Practice and Training, and I will share that most of this information will be used by you guys in your practice at UAB. And for all of you, you can use this information when you advocate for your loved ones who may be in the hospital. So let's get started. We have some objectives because that's always important. We're going to talk about the importance of safe mobility, discuss considerations, and discuss strategies for maintaining function. So we'll get started with a little knowledge check here. So I have 11 questions. You can kind of read along as we go here and think about it. So true or false, almost all older adults need rest to recover and should be given total assistance during their ADLs. So this is actually false. What we want to do is make sure that patients stay engaged, and we do that by letting them do everything they can independently. Number two, select all that apply. Immobility results in which of the following: increased workload of the heart, slower digestion, increased risk of incontinence, or all the above. So the bed is not your friend. So unfortunately, prolonged bed rest can result in a myriad of bad things, including slow digestion, incontinence, and muscle wasting. So which of the following? Is not a barrier to hospital mobility? So bed rails, nighttime sleeping, IV poles, urinary catheters. So here the idea is tethers. So we want to make the right choice the easy choice. So what keeps patients in the bed or makes it hard for them to get out of bed? We want to remove those when we can. So nighttime sleeping would be the best, not a barrier. So true or false, immobility affects the muscle skeletal but not digestive. So actually it affects both. So remember, the bed is not your friend. So true or false, watching for changes in older adults' patients' ability to participate in activities of daily living each day is an important way to measure functional decline. And here this is true. So what we want to do is oftentimes older patients may not be able to have a fever response or may not have other indications that loss of function is the first red flag we may see. Number six, everyone has a key role, and this is true, and we mean everybody: patients, families, and us as care providers. True or false, bed rest affects every system. Third time we've had the question, so we're going to go with true. And then number eight, select all that apply. To maximize functioning, you should do what? Maintain routine, encourage range of motion, provide social activities, encourage ambulation, all the above. And the key here is that creating a space for safe mobility is a multifocal approach. We need to make sure patients know what their goal is. They have a reason for wanting to get up and do things. And we need to make sure that we encourage that as much as we can. And then true or false, a downward spiral of function is common, but there's little we can do. So unfortunately, it's very common, but there's a lot we can do. And this whole presentation is about what we can do to prevent that functional decline. And then every day of bed rest requires 2 days. This is true for our older adults. And then functional decline occurs by the second day, and this is true as well. So again, just to kind of set the stage on what we're going to talk about, we have some key words here I want to go over. A lot of times in the hospital, we throw around these and people are like, what? So delirium is an acute change in cognition or confusion state. It's often reversible, and mobility is a key intervention. Pain is whatever the patient says it is. Mobility is a key intervention for pain. Immobility is the lack of movement or impaired function. Functional decline is the inability to loss of function or mental abilities. We specifically talk about activities of daily living in the hospital. These are things patients must do in order to live independently at home. So we really hyper-focused on making sure we know what the patient's functional status is at baseline and helping them get back to that independent status if that's where they were. So bathing, feeding, dressing, toileting. Care transitions is really how do we at the hospital think about the next level of care and how do we get patients to that next level of care. And the reason this is important for mobility is if we don't provide safe mobility in the hospital, patients get weak and deconditioned, and it complicates the transition of care. They have to go home with more care than we planned. So again, that transition of care is complicated when we don't address pain, delirium, and mobility. So I have a little thought experiment for us to think about. And the idea here is that mobility is really about quality of life. So when a patient loses independence, they're going to lose their social relationships. The quality of the relationships changes. So I'm no longer the son, I'm the care provider. I'm no longer the spouse, I'm the care provider. The quantity also changes. Maybe I don't interact with my friends as much as I used to. I don't get out. I can't get out as much. So I lose independence. I have changes in social relationships. And then I have this tape playing in my head, telling me maybe I'm a burden, or why did this happen to me? I have a spiritual crisis. Why did God let this happen to me? And all that manifests as a psychological change. So you may see depression, anger, anxiety, and patience. So I share this with you because when we think about our role in healthcare, it really is about alleviating suffering. And so when patients leave the hospital with a functional decline, they and their families suffer. Now, the suffering may not be permanent. They may make a full recovery. They may come to acceptance with where they are, but for a window of time, they suffer. So if we can prevent a functional loss or functional decline in the hospital, we can prevent suffering. That's why we focus so much on safe mobility and functional assessments. So why is it so important? Is this all the bad things that happen to me in the bed? So you need to have 2 or 3 of these in your back pocket so you can educate families on why mobility is important. So it may be, I want to see you out of that bed. I want you taking those deep breaths so you don't get a pneumonia. I want to make sure that blood circulates in those legs so you don't get a blood clot. We want to get those bowels waking up so we can get your bowels moving. We want to make sure that you stay strong and keep your strength up. So these are the reasons that patients need to get out of bed. I want to see you eating in the chair. I'm afraid if you eat in the bed, you're more likely to choke or aspirate. So this is just some data showing why we focus on mobility in older adults. So as we age, you can tell on the top versus the bottom, as the white is adipose or fat tissue, the dark is muscle. As we age, we lose muscle. So yes, safe mobility is important for everyone, regardless of how old you are, but it's very important for older adults. If you don't use it, you lose it. If you don't have it to start with, you're kind of more likely to lose it. So this was just showing what I just showed you. Okay, so what do we know though is that the hospitals really aren't the places for safe mobility. Patients spend about 20 out of 24 hours a day just laying in bed. Now, we often justify this by saying, well, patients are in the ICU and they're so sick and da, da, da. Yes, there are some patients who are too sick to mobilize or get out of bed. That is absolutely true. But that is not the vast majority of patients. The vast majority of patients walk in the hospital and can walk on in here, and we do not create a space for that, and that's on us. So how do we create that space for safe mobility? So again, thinking about what happens if patients do lose function and decline in the hospital, it's very hard to get that function back. So if you think about an older adult who loses function, a third will recover, a third will be alive but not recovered, and almost 40% will be dead if they lose, if they have functional decline at discharge. So the stat that I use with my family is this one bolded at the bottom, this 17%. So what I think about is when you leave the hospital, you have a window of time to get back to your baseline. If you don't get back to your baseline within 30 days of discharge, chances are you're never going to get back to that baseline function. So this is why it's so important that family members and patients are active in the hospital so they don't lose function and get behind the 8 ball. And when they go home, they maintain their healthy routines and participate in therapy if it's prescribed so they can get that function back. So what we see is that loss of function is often the first domino that falls that sets up the cascade that leads to patient's death. So you lose function, you get weaker, you have some falls, you get into your bed bound, you get a pressure ulcer, you get confused or delirious, we put you in restraints, you have an aspiration event, you get a pneumonia. It just keeps going one domino after another. And if we go upstream and look, the first domino is often that loss of function. So we know that safe mobility can decrease pain, improve mood, improve cognition, improve functional, and decrease adverse events such as falls and pressure ulcers. So mobility is the right thing to do, but why don't we do it? So there are a lot of barriers to safe mobility. And probably the biggest barrier is this fear of falls. So we want to make sure we address the fear of falls. How do we encourage mobility, but do it safely. So if you say, Dave, don't get up, we're afraid you'll fall. We want to say, instead, we want to say, Dave, we want you to get up. It's very important you take those deep breaths. I'm concerned about X, Y, Z. And so this is what we're going to do to make sure you get up safely. And that safely is your fall prevention bundle. Bed rest can be an issue. So sometimes patients have an order for bed rest, and that's completely appropriate. But you need to ask the question, when does this order expire? When will my patient go to get up? And then tethers, those things that keep patients in the bed. We want to make the right choice, the easy choice. Do we need the oxygen, the IV, the telemetry? And if we don't, can we take it off so we can get up more easily? So when we think about self-fulfilling prophecy, these are things you might hear staff say, and we always want to think about the other side of this. So don't get up, we're afraid you might fall. Well, we want you out of the bed. So how do we do that safely is by saying, okay, our goal today is for you to get in the chair. I'm concerned. It's your first time getting up. You have all this stuff attached to you. You might be a little unsteady or fall. So to get up safely, this is what we're going to do. And that's your fall plan or your safe mobility plan. Sometimes we hear, I'm glad she's sleeping all day. Well, that's okay to take a nap, but if you're sleeping all day, you can't participate in mobility, nutrition, or activities. So you want to make sure there's a space that they're up doing those things. And then, making sure patients look their best. So yes, in the hospital, patients are often, disheveled. They don't feel good. They may not look their best. We need to remember at baseline, what was this patient like? How do we get them back to that? So I want to spend a little time about falls because we're talking about safe mobility here. So a fall is an unplanned descent to the floor. So anytime a patient's butt hits the floor, we get concerned that was a fall. And we want to know about patients who trip in the hallway and fall. We also want to know about patients who slip out of their chair and fall in the room. So we want to capture all that so we can learn from it. So what do we do for safe mobility and fall? Well, the first thing we do are safety huddles. Every team, every unit has a dedicated time where they huddle and talk about safety concerns. Mr. Smith is a fall risk. Mr. Bed 5 is getting a new medication. We want to watch for a reaction. So making sure we're looking at those concerns. The most important intervention we have for fall prevention is our purposeful rounding. Now, I'm going to stress purpose over hourly. So it is important that you consistently check on patients. That's why I call it hourly. But a lot of staff get really caught up on making a game. Every 60 minutes, they do a check on the patient. And that doesn't make a difference. What makes a difference is addressing the 4 Ps proactively. When you're in the patient's room, address pain, potty, position, and possessions. And if you do that proactively, you're going to prevent the patient from falling because patients get up to go pee without you and fall. Patients get up to get their cell phone across the room and fall. So by addressing the 4 Ps, you actually reduce falls and you improve your efficiency because you're not a ping pong ball going from room to room. In addition to our purposeful rounding, we also can implement other strategies such as yellow socks and armbands to identify patients who are fall risk outside the unit, low beds, scheduled toileting. So patients, if you ask them they need to go, they probably need to go, you take them. So those are all interventions to reduce falls. And again, that idea, don't get up, we're afraid you'll fall becomes, it's very important you get up today. This is what we're doing to make sure that happens safely. I'm going to be with you. We're going to have these non-skid socks on. We're going to use this gait belt, etc. So what do you do if a patient does fall? Well, your first and foremost priority is to the patient. So unless it's absolutely essential, you should stay with the patient. You can call out, you can push the call light, but just stay with the patient, provide that emotional component. Oftentimes it's scary, provide the emotional support. The RN will come in and do an assessment, and based on that assessment, decide what the next step is. Do we get the patient up? Do we need to go to CT scan? The provider need to assess the patient, whatever. Once the dust is settled, the patient is stabilized, then you're going to want to document what happened. And this is very important because this is how we learn how to prevent the next fall. So trend trackers are our documentation system for incident reports. They are non-discoverable, which means they cannot be used in a court of law. So you feel free to put the facts in here because it's not going to be discovered if we are sued. But you do want to share the facts and just the facts so that we can learn from that learn what happened. So how can we provide safe mobility for us? Because it's not just about patient safety, it's about our safety. And we do that through our safe patient handling equipment. So we have gait belts, we have safe patient handling equipment on the units, and these are all tools to help you provide safe mobility for patients. So every unit has dedicated equipment based on our unit patient population, and your preceptor will review with you specifically the equipment you have on your unit. So to help you put all this together, we have our MOVE protocol. So the MOVE protocol is for mobilized patients daily. So remember, the bed is not your friend. How much time can you get them to spend in the chair, doing their activities of daily living, watching TV, coming back from their test or procedure, getting in the chair versus back to bed. O is for optimizing pain, making sure we have a plan for pain and make sure that we're coordinating our interventions with our pain meds, but also advocating for non-pharmacological pain interventions. So we have music therapy, pet therapy, massage therapy at UAB. If you think your patient would benefit, talk to your nurse. You can use hot packs and cold packs. And remember, getting up and moving around is a pain intervention. Oftentimes just being in the bed gets stiff and sore, and that moving can really help. Doesn't feel great when they do it the first time, but it does feel better later. And then V is making sure you verify and communicate the plan. Who's doing what for mobility? What is therapy doing? What is nursing doing? What are you going to do? Does the patient and family know what the goal is for the day and the schedule for that mobility goal being achieved? And then educating, making sure patients and families know why safe mobility is so important. How does this connect back to what matters to them? So make sure you connect to their goals and their values. And then providing that documentation on the whiteboard or communication board for what their goal is for the day and how we're going to get there. So to help you document and keep up with all this, we used a modified Johns Hopkins mobility scale. So 1 to 8 scale. PCTs will document this along with the RNs in the patient record, and you document the highest level of mobility the patient does during your shift, and then you use that to set the goal for the next shift. So it's a way to monitor progress of patients' mobility. We also have gait belts. If you haven't used a gait belt, I would encourage you to try one for 2 weeks. You'll be a fan. Your preceptor can show you exactly how, the mechanics. But a couple tips for gait belts is that they're really about you. So the gait belt is not about the patient, they're about you. So the script I use with my patients is, I'm going to use this gait belt. It's going to give me a safe place to hold on to. So it's about me having that safe place. Then when we think about using the gait belt, we can actually apply the gait belt and simply have it as a place to walk alongside the patient to coach them, or you can actually use it to help assist the patient to a standing position. So some special considerations, the gait belt can go around the waist, but if they have a colostomy or a PEG tube or surgery or pregnant, you can go above around the chest is completely appropriate. So the 2 takeaways for gait belts, it's a tool for you, and it can go anywhere on the torso from the waist up to the chest. We're not going to do that Zoom. We're not going to do an activity, but I do encourage you. There are available on the units to practice if you haven't used one with your preceptor. If you do a 2-week challenge, I guarantee you'll be sold on. So for safe mobility, we have a couple of different algorithms and protocols we use. What I want to highlight here is that for our pain protocol, as well as for our delirium or confusion protocol, safe mobility is one of our primary interventions. And I share this because when you guys provide safe mobility, when you prioritize mobility for your patients, you are addressing pain, you are addressing delirium and confusion, and you are helping make sure patients get back to what matters to them. So be the patient advocate and advocate for safe mobility. So with that, I'm going to pause. If you have any questions, anything's fuzzy, just please reach out. Thank you.